Good afternoon, everyone, and very welcome in today's Nursing Academic Webinar session. Myself, Shanti Bhattacharya, the Vice President Nursing, Yashoda Hospitals, and today will be as your moderator today for the session. Let's welcome our expert panelist, Dr. Prabakar D, who is our very eminent, highly competent, highly skilled vascular, endovascular, and senior consultant at Yashoda Hospital, Secunderabad. Thank you, sir, for accepting the nursing webinar invite.
Yeah,
and let me also introduce our very charismatic and passionate nurse educator, none other, Miss Sushma. I welcome you, Sushma.
Yeah.
And the topic which we are going to discuss is on the very long-standing morbid and the vast topic on diabetic foot ulcers, and let us see its effectiveness along associated with the VAC therapy, which is nothing but vacuum associated closure device. As you all know, as per the National Institute of Health survey in Indian population, out of 62 million populations, 25% develop diabetic foot ulcers, of which 50% become infected, requiring hospitalization, while 20% need amputations. These chronic ulcers are so much contributed to the annually contribution to the catastrophic pandemic, as I think sir will also agree, and we will also like to listen from sir. So the first awareness we would like to know from sir, maybe this prevalence or the data which I had spoken just now, maybe a scant data, but as per the prevalence or the as expert, what kind of the cause, the causative factors where patient comes to you, and what is the main factors which is among the Indian population they come and seek your attention, sir? The question to you.
So mainly it is diabetic foot ulcers. The reason being they will take treatment for diabetes. They don't know how to take care of that foot.
Yes, sir.
So it is awareness about how to take care of foot is very important. Most of our Indian patients still now, even now they are having barefooted walking. And trivial traumas in the foot with presenting with ulcers, discharge. These are the common symptoms these diabetic patients present to us. So now India being 140 billion population now, India is going to be the diabetic capital of the world. And of which 20% of these patients, they are prone for some of type of diabetic foot infection. Of which 1 to 2% of patients, there is a chance of risk of very amputation. Can be a minor amputation at toe amputation, or at major amputation at foot level or below knee or above level amputation. So the risk of amputation is very high in case of neglected diabetic foot ulcers, or in those patients where it's not been treated properly. So because of aging population and increased diabetic patient, in future we are going to see a lot of patients with diabetic foot problems. So we need a comprehensive care for these type of patients where good medical team with wound care specialist. So we need to assess these type of patient with a proper care so that to prevent amputations in future.
So let's see what we have in the rest of the session. Over to you, Sushma, for the rest of the session.
So, good afternoon, one and all. I'm Sushma, educator from Nursing Education and Training Department, Yashoda Hospitals. So as sir told us, like in future, we are going to look in there are many patients who are coming with a diabetes mellitus. So I just wanted to brief about what is exactly the diabetic foot ulcer. And it's nothing but an open sore or a wound that occurs in approximately 15% of patients with diabetes mellitus, and it's commonly located on the bottom of the foot. So here, near about 415 million people are suffering with diabetes mellitus. And in upcoming 25 years, we are going to expect globally 51% of people who will be suffering with diabetes mellitus. So that is the reason today we are going to tell you about the effectiveness of VAC device and the patients who are suffering with chronic diabetic ulcer. So here, first let us brief about diabetic foot ulcer. It's nothing but a person with affected with the infection along with diabetes originating in a chronic or acute injury to a soft tissue of the foot, which is evidenced of pre-existing neuropathy or ischemia, or else it may be due to peripheral vascular diseases. So here we can see in the third slide. So it's a non-healing wound in the simple words. So according to the Wagner's classification, so Wagner's classification is nothing but they classified the diabetic wound into like grade 0 to grade 5. So grade 0 is nothing but here we won't see any ulcer here. So no ulcer, but the foot may be at the risk of ulceration formation. So if we look into the grade 1, it's a superficial ulcer, and grade 2 is a deep ulcer, grade 3 abscess deep ulcer, grade 4 is limited gangrene, and grade 5 is extensive gangrene. So if we look into this image, we can tell that it is a deep ulcer where there is no healing. And the next, so this is the necrotized wound.
Sir, here we would like to ask sir, go to the previous slide, which is your third slide. Very great that you have provided the information about the Wagner classification. And we all, as a nurses, we know that the wound healing goes through 3 maturative process or phases. So here, if sir, when you receive such clients with a non-healing wound, in simple words, what is the intervention which you provide from your end?
Now, whenever a patient comes with a wound which is not healing for more than 2 weeks, then we will call it as non-healing or chronic wound. So all these patients, they need proper evaluation. So why the wound is not healing? Whether it is due to uncontrolled diabetes, or it is due to malnutrition, or whether it is due to hypoalbuminemia, low in protein, or any blood circulation disturbance like any peripheral arterial ischemia, any arterial blocks, or any venous disease like varicose veins or old deep vein thrombosis, or especially in case of diabetic associated neuropathy. So long-standing diabetic neuropathy, they will go for autonomic dysfunction. In these patients, there will be bony abnormalities where they may have like heel ulcers, or hammer toes or toe tip deformities. So because of neuropathy, they will have pressure ulcers. So what is the exact location of the ulcer and how long it is? What is the reason for not healing? We have to assess.
Yes.
And as per the diagnosis, we have to treat, then these ulcers will start to heal.
Over to you, Sushma, for the rest of the slides.
So this is the worst necrotized non-healing wound. If we look into this image, we can directly tell that there is no proper blood supply and completely the foot has been necrotized. So it's completely damaged.
Yeah. So I think this kind of patient, when they report to you or they try to seek your medical attention, I think this is the criteria for the total amputation, or what else we can do to salvage the limb.
Yeah, as I told, no, first we have to see, especially in diabetic patient, foot ulcers. It can be a neuropathic ulcer, it can be an ischemic ulcer, or neuroischemic ulcer. That is the combination.
Yes.
The neuroischemic ulcers are most common actually, most of these patients. So when there is decrease in vascularity, we should try to improve the vascularity. So now we have various modalities to diagnose, like we have advanced vascular lab to study the pressure index studies. We will do digital subtraction angiogram to locate the exact site of occlusion, and then we'll try to revascularize. We will do tibial angioplasty or bypass to improve the circulation, followed by an adequate debridement or partial toe amputation. So that helps in wound healing. So if we don't intervene in this patient, he will end up with below knee or above knee amputation. But after revascularizing, if you intervene, this patient may end up with only 1 or 2 toe amputation. Still, he may have intact foot and a limb can be salvaged.
Yeah, over to you, Sushma.
Yes, ma'am. So this is like after post amputation finger of the leg. So here the patient has got necrotized, the foot has been necrotized and it has been amputated overall fingers.
Yeah, exactly. This is after revascularization. You can see the red granulation along the skin. So after revascularization, post amputation, the wound looks like this.
And next, if we can see after amputation, then this is the kind of the wound where it is a beefish reddish in color, and I think it's a good circulation is going on.
Correct.
So this is diabetes plus followed by cellulitis wound where there is infection.
So as you said for the previous slide, I think those underlying causes has to be first assessed. Then only we can go for the limb salvage criteria. Yes, over to you, Sushma, for the rest.
Yes, ma'am. So if we look into the pathophysiology, so as Sir told us, like the cause may be like neuropathic cause. So neuropathy is nothing but, as we all know, it's a damage to the nerve endings. So here what happens, again, this neuropathy is divided into autonomic neuropathy, sensory and motor. So autonomic is nothing but here what happens, here the involuntary or spontaneous nerve endings like peripheral endings will be get damaged, and where the patient will have like feel lack of sensation. And whereas coming to sensation here, exactly completely they will lose the sensation part, where they also experience like numbness or tingling sensation in their foot. And the next coming to motor is completely weakness or like weaken of the peripheral muscles, peripheral this thing. Either it may be hands or leg, but most probably we can see it in the foot area, phalangeal region. So after this, what happens here? Due to abnormal pressure points. This abnormal pressure points is nothing but in the phalangeal region, we can see mostly this diabetic ulcer will be affected to the fingers, toes especially. And this is only because of either it may be due to pressure, lot of pressure, or else due to directly like barefoot walk and there is lack of blood supply, or else there may be a chance of no sensation in their peripheral region. So, and one more cause is like callus. Callus is nothing but it's a dry skin. So these are the few causes where we can see the patient will not experience any kind of pain, and there may be a chance of any breakage of the tissue, damage of the tissue, and they won't, they don't know the exact reason. And further, what happens? It leads to ulceration, and the ulceration later there may be a chance of bacterial harbor, and because of that, it finally leads to infection of that site. So this is the general pathophysiology. So there are many causes. I can tell you diabetes where there is a prolonged diabetes, and the next venous insufficiency where there is lack of blood supply to the peripheral region, and also hypertension. Hypertension is like a slow healing takes place. And whereas
here we would like to ask again, sir, the cause factor for the diabetic foot ulcer, one of the very major cause is also hypertension. Sir, can you just give us a little insight on why hypertension will rise to the diabetic foot ulcer?
No, hypertension per se won't cause to diabetic foot ulcer. The diabetes, hypertension, hypercholesterolemia, these three factors, they will increase the thickness of the vessel. So they will go for atherosclerosis, arteriosclerosis, thereby reducing blood circulation to the foot. So which leads to recurrent foot ulcers.
Yeah.
The main cause of foot ulcer in diabetic patient is neuropathy. Because of sensory loss, trophic ulcers are more common. And if they don't take care of it well, they will have web space infection. And definitely the associated vascular insufficiency will lead to chronic ulcers.
Yeah. Next.
And there are a few more causes for foot ulcer. Blister formation. So there is a lack of sensation in the lower extremities. So sometimes there may be a chance of blister formation where it will be neglected and further lead to ulcer. And the next, dry skin. If they're not taking care properly of their skin when it is dry, and there may be a chance of breakdown of tissue. And as I told you, callus formation, it's a dry skin. And the next, fungal infection. And this is peripheral vascular diseases where there is a lack of blood supply to the lower extremities.
So I think in the Indian scenario, especially in the rural areas, this dry skin and calluses are very, very common, and it is very much ignored factor. So if this calluses is very common, and if somebody comes to you in your OPD, what primary interventions would you suggest? Maybe it is among healthcare workers, maybe it is among nurses, maybe it is among many healthcare professionals. So what would be your advice?
So basically, we need to create awareness, or we have to educate them how to take care of the foot. So what we do advise to our patient is we'll ask them to look at their foot daily before sleeping. See, like how they are seeing their face in the mirror. So every day they should look at their foot. and the web space. In between toes, they should check. These are the common sites where infection may occur. If they identify any hard skin in the beginning itself, then they should assess their foot pressure study. So thereby footwear modification has to be done. The pressure offloading will be done so that these callus and cons will not worsen. And if there is a crowding of toes, there is like a separator. Toe separators are there that will prevent crowding of toes, that will prevent web space infection. And definitely to prevent fungal infection, they should keep their foot dry and clean. And every time patient, any diabetic foot patient, if you see also, we should feel for peripheral pulse. If there is absent peripheral pulse or reduction in the flow, then that has to be attended immediately. So that is how these peripheral vascular disease, the diabetic foot clinic is for that purpose only. So not only treating diabetes, these patient foot has to be assessed in a systematic manner, where the neuropathy, vasculopathy, trophic, all these has to be addressed in a comprehensive manner.
So for this dry skin and all, like you can, I mean, we can also start moisturizing our legs, as you said, before we sleep or we look at our feet.
Yeah,
and then we can
definitely. They should wash their feet daily at night before going to bed. They should dry it clean, apply moisturizing cream. These things will help in the prevention of callus and cons.
Thank you, sir. Next, Sushma.
Yes. So these are few risk factors due to prolonged diabetes, where there are no control of the sugar levels, and there may be a chance of smoking and the poor circulation, as like peripheral vascular diseases, when there is lack of blood supply to the peripheral area, and obesity is also one of the risk factor. And especially we can see this in the older age people because of their skin elasticity they'll be losing, and it's a skin condition. So this is the conventional wound dressing with these are the I can tell you loss of less benefits. So here, the main intention is to tell you about the VAC assisted devices. I hope many of you doesn't know about VAC devices, but it is a present process where the wound healing takes place very easily. And this is the vacuum pump which we are using. And then next, this is the tubing, which has the sterile foam dressing. There are two types of sterile foam dressings. One is polyurethane foam and polyvinyl alcohol foam dressing. So it depends upon the patient condition, they will use different kinds of foam dressings. And whereas this tubing will be connected to the canister. Canister is further, I'll show you the jar. This is a jar where the complete all wastage, whatever the secretions are there, will be collected here. And it also has the measurement part where it will be helpful for us to measure the output easily.
So here again, I'd like to interrupt you, Sushma. Go to the 12th slide, which is talking about the conventional wound dressing with where the increased length of stay of the patient and it used to be with less of benefits. So now we have come to the very great modalities of treatment like VAC therapy. Yes, and then, so we would like to hear from sir, the population who is seeking your attention or your treatment. What do you say, sir? Conventional wound dressings are very well accepted now, or they are just opting out for VAC, and whether are you taking their consent in terms of cost and minimizing hospital stay and better outcomes? What is your take on this?
Different wounds require different type of dressing. VAC is one assisted wound dressing. Now VAC is in practice for more than a decade now. Of all the treatment modalities, this is a very promising treatment modality, but it has its own limitation, advantages and disadvantages. Not all patients require VAC therapy. So where VAC is required, where there is a lot of soakage or seepage of the wound, macerated wound, a large area of the wound, where VAC is very helpful. If there is a small wound, it is clean, dry wound, there VAC is not required. There still we practice conventional wound dressing only.
Wound dressing, yeah.
Few patients, they may require assisted wound care with collagen dressing. where there is only the dermal component, like skin epithelialization is inadequate, there is no seepage, their collagen dressing will help. So VAC is restricted to those patients where large wound areas with significant soakage. To be precise, if there is more than 100 ml per day of soakage, VAC definitely will help.
So we will also like to see the indication and contraindication. Sushma, you can just go to the slide, or maybe 14th slide, you can just explain.
Yes, here this VAC help us the wound heal in a better way. As just sir explained, according to the condition type of the wound, we will choose whether it is a VAC device or conventional device. So this device is launched by the machine Lohmann and Roscherger, and this is like from Doctors Reddy's, and especially in Yashoda, we are almost going with the same VAC device. So this is the canister. As I said, it's like to collect the secretions, and it also has a measurement scale where we can measure easily the exact output. It will be help us in the output documentation. And these are the few indications and contraindications of VAC device. So the first indication I can tell you, it is diabetic non-foot ulcer and worsened pressure sore, skin graft and flap salvage, chronic major wounds. If there is any major wounds, then we can go with the VAC device. And if there is any major surgeries also, and crush injuries, and the next delayed extravasation. Extravasation is nothing but when there is infusion of vesicant drugs, then there may be a cause of damage to that tissue area, and sometimes it also leads to a necrotizing of the tissue also. And these are the few contraindications. First contraindication is untreated osteomyelitis and the presence of necrotizing tissue.
So this is all dealt by sir, that he has already clearly explained when VAC is to be indicated, when not to be indicated. Next slide.
So what is the exact function of VAC device? So what happens here, the main specific function is, first thing is it creates a negative pressure VAC device. And then next, whatever the secretions are, if you found there is a severe edema at the wound site, then it removes the extracellular fluid from that area where the edema will be decreased. And also because of decreased air pressure, what happens, easily wound healing takes place. Like early wound healing will be happening with the help of VAC device.
So here the concept and the working functioning of this device is about negative pressure wound therapy, sir. I think you will agree. And one of our, we would like to know is what kind of pressure we got to set. I mean, though it is done by technician, but as a nurse also, we would like to know, is it going to be a big wound where a lot of edema and a lot of secretions? And what kind of pressure? Is there any limitation of setting the pressure as well?
So normal, negative wound pressure will be around -100, roughly around 100.
Yes.
If the soakage is more, they can keep more at 120 also. If the soakage is less, you can reduce it also. As such, the pressure does not affect the wound healing. It depends on how much of soakage and the surface area of the wound.
Next, Sushma.
So this is the exact VAC application, like how do we apply the VAC device? So wherever there is like amputation or any wound, so there is a placement of the flap or else a firm dressing, and it will be connected to the tubing and it's directly connected to the VAC device. So where they will set the pressure and it will be going on functioning. And it's mainly important, like we have to check the whether it is on or off, and continuously it should be like charged. So you can see it is completely closed.
Next slide.
So leg flap with VAC device. This is one kind of flap where it is completely covered with the firm dressing, and also a tubing is placed, VAC tubing.
So I think what could be the hospital stay when the patient is with a VAC, and this sort of images where we are talking about maybe minimum less than 5 or more than 5, or what is the length of stay? So
in conventional dressing, we may need to change the dressing daily.
Yes.
The advantage of VAC therapy is we can change once in 5 days. So for wound dressing care, we no need to admit the patient. This patient can be discharged with this VAC machine. We have to teach about them how to connect or how to monitor the functioning of this VAC thing. and they can visit us once in 5 days. This is one of the main advantages of VAC therapy.
Next. So I think we also wanted to just browse a little bit about when I was going through a lot of study and meta-analysis and all the review of literature as per the American Journal. The conventional techniques have been since the long time for the management, but yet, as sir also has agreed, that it doesn't serve any purpose and a lot of hospitalization is required. But thus, this novel technique is really, really very great helpful. And the benefits, second slide, Sushma. The benefits also, I think the good compliance, admission is not essential. As sir also has said, patient can come to OPD and require minimal training to maintain vacuum at home and can be applied to multiple cases at the same time and give adequate mobility. I think it is not restricting patients, mobility to one place. The patient is not chair bound or bed bound. Patient can have his mobilization. But what my question is, sir, to you, like Hyderabad, like a developing country or state, we see this VAC, but I don't think that in the other state this device is still launched, or maybe it is not there or underutilized.
Yeah, it is there. See. The principle of VAC therapy is there for a long time. So even 20-25 years back when we were in medical school, how we did is we do dressing. We have our suction machine. You can see in the OT, the old suction machine.
Yeah.
We used to connect that to those dressing. This is one of the modality for a long time. But because of newer techniques and newer thing, we have a mobile machine with us now.
It is finally
correct.
Modified.
Compared to a decade back, now these new machines are very cost effective. So over a period of time, definitely we'll get cheaper machines.
Yes.
Patient affordable machines will come. It will go to rural areas also.
And majority of the patients are opting out for this device actually. Yes. Next slide, Sushma.
Yes. So here nurses play a very important role. Like few things we need to check here. First, confirm the device, whether the negative pressure has been set or not, and make sure that it should be charged. Ask the technicians if the nurse is handling the device, or else, as sir told us, they can also get discharged, go and take care at their home. So we have to teach them how to use this VAC device. And main thing is like we need to ensure that there should not be any kinking in the tubing, and make sure you need to check that there should not be any leakage or clamps over the tube. And this need to be educated to the nurse as well as to their family members also. And check the fluid output. So we need to measure how much is the output of the discharges, and we need to also assist in the dressing part. So whatever it's there, so make sure that we need to address if there is any alarm. Suddenly there is an alarm, so we check that why the alarm is due to. So it may be sometimes because of kinking in the tubing, or else any leakage, or else sometimes there may be a chance of battery low. So always it should be charged.
So sir, here the reason for alarm, whatever factors we have just mentioned here, is it the same? No sir, if there is a leak or device is low or fluid column is not moving in the tubings, is that the same thing?
Is there one more thing is if patient complains of pain.
Okay, yes.
We don't know the reason, but patient on VAC therapy sometimes they may complain of pain. In that case, we have to stop the machine. Then we need to have assisted care
and escalate. Yes.
Yeah.
Next slide.
So patient education. So when the patient is on VAC device, we also need to educate them regarding the sudden there may be a chance of fever, redness over the VAC device, swelling, warmthness, or pus formation, or else we can also see sometimes a foul odor also, and itching or rash. So these are the things we need to educate the patient, followed by the nurse also needs to observe for the signs and symptoms. And if there is any excessive bleeding under the dressing, we also need to inform to the physician. Avoid getting the electrical device wet. So as they will handle this device at their home services, so we need to also teach them that when they are going to take bath, or make sure that it should not get wet. So they need to disconnect the device and also make sure that it should not get wet, because the main thing wet it doesn't make cause the negative pressure. It will slow down the negative pressure. So educate the patient to disconnect the VAC until from the tubing and clamp the tubing before bathing. And the next to follow dressing as per the doctor's order, and they cannot do their own dressing. They need to come to the hospital and make sure the dressing is done for every 5th day. And if there is any technical issue, immediately they can contact the technical person. And nurse should be trained enough to handle the VAC or own management. So here we can teach them how to disconnect the VAC device, and when there is an alarm, so what is the reason exactly for the alarm? They need to check for the kinking of the tubing and discharges, any leakages, and also the site of the wound.
So here, sir, when the patient is being discharged with a VAC therapy at home, so they can always disconnect and go and take their shower, I guess.
Yeah.
Yes, they can do that.
Connecting, they can do that.
Yeah. So thank you, everyone. Yes.
We teach the patient and their attenders also.
Yes.
How to take care of this VAC machine.
Yes.
When they have to be careful. Yeah.
So this is the end of the session today, and thank you, sir. And I would like to convey one message to across the nurses that we have very beautiful diabetic food clinic, especially at Yashoda, Secunderabad, under the supervision and guidance of sir. Sir is a very passionate mentor. He always loves to teach the nurses on the wound management and how they should, tissue viability criteria and all. So thank you, sir. And it was a very great session, and we came to know a lot of very great points, like when there is a pain, the patient should, escalate, and the setting of -100 pressure for the VAC therapy device. Thank you, Sushma, for all your effort, and let's see what we have for next Thursday. Thank you, everyone, and that's the end of the session.
1 minute from Yashoda Hospital, Secunderabad. Now we have diabetic foot and advanced wound care clinic in Secunderabad. So any nurse or staff who is willing to or who are interested in wound care management, we are happy to help them. They can come, they can see the patient here. We are treating more than 200 chronic wound patients per month. So we have all modalities of treatment. We have VAC therapy, we have collagen-based therapy, we have simple debridements, advanced debridements, vascular, neuropathic, offloading correction, everything. If somebody is who are really interested, can come over here. We are ready to help them. We are ready to teach them actually.
So instead, we can go for the certification program for all such new technologies which they will learn under you. Thank you so much, sir, for your beautiful guidance on the same. And we would love to have those sessions for the nurses of Yashoda and across. Thank you. And this is the end of this.